The National Programme for IT, Lessons in Project Risk Management, PSMP 5210, Project Risk Management, Dr. Michael Powers. Team assignment, Spring 2018. Pam Denninger, Christina Dubrovic, Rachel Duzick, Stephanie Gibbons, and Dave Grills.
The National Programme for IT, NPfIT, stands as the world's greatest and most expensive IT failure. It offered a complete overhaul of the National Health System, NHS's full range of systems, and would have significantly changed the way 65.5 million people used the NHS. The main purpose of the NPfIT was to create national electronic health records, although additional sub-projects included an electronic system to book hospital appointments, new broadband infrastructure, and e-prescriptions. Everyone acknowledged the need, and it started promisingly, with full support by all leadership. But even so, it was one of the riskiest undertakings as it was so large and so innovative. The project officially kicked off in early 2003 with a budget of £2.3 billion. Prime Minister Tony Blair wanted the project to finish in time for elections in 2005. It quickly started emerging that the new procurement methods negatively impacted the project, and by the end of 2005, the project's end date, very little had been accomplished, and the project was already £2.7 billion over the initial budget. The budget was raised multiple times, and delays were so frequent that experts estimated the project would only be completed by 2020. In 2011, after years of increasing costs and little payoff, the government was called on to shut the project down, which it formally did on March 31st, 2013. There is no census on the final cost of the project, however the estimate is £10.7 billion. An electronic patient record, EPR, is an online record which is comprised of a series of software applications which bring together key clinical and administrative data in one place. This has the advantage of significantly decreasing errors, as they are more legible than paper records and have added details. As they are online, it means that they are far more accessible and thus will improve emergency care and ensure any professional involved in the care of a patient knows the current status of care. Furthermore, EPR systems can vastly improve the accumulation and dissemination of information on public health, and can be used to inform public health policy by mapping, for example, a disease's resistance to antibiotics. The NHS had many attempts at EPRs since the late 1980s, however most of them had failed. The NPfIT would have provided a centralized source for all EPRs, and there was sufficient technological progress that a unified program could be made for all of the United Kingdom. Along with these principles, there were 6 main outcomes. Number 1, there would be lifelong electronic records for every person in the UK. Number 2, National Health System clinicians would have 24-hour-a-day online access to the relevant patient information necessary to aid them. Number 3, patients would have ready access to accredited and independent advice about their condition, including telemedicine. Number 4, healthcare professionals would always have the latest local and national guidance and evidence on treatments and tools to evaluate their clinical effectiveness, including best practices. Number 5, health planners and managers would have the information they need to use the NHS resources effectively. Number 6, the public would have access to fast and accurate advice on lifestyle, health, and information to support their care. The stakeholders included everyone in the UK, from the public to clinicians and all leadership. The patients would be able to use EPR systems to see their own test results from home and to understand the NHS performance data. Healthcare professionals would be able to use the EPR systems to gain access to fast, reliable, and accurate information about patients' local and national knowledge bases and information to support them in their work. NHS managers and planners would be able to use secondary data from the EPR systems to gain access to high-quality information that helps them target and utilize resources. The public would be able to use secondary data from EPR systems to assess the performance of local hospitals and other healthcare service providers. The relevant leaders of the Prime Minister, the Secretary of State for Health, the Parliamentary Under-Secretary of State for Health, the Director of the Department of Health, and the Chair for Office of Government Commerce.
There were several warning signs that the National Programme for IT faced a wide range of scope risks. The first is size. Large programs are inherently risky. The second is the poor history of the National Health Service in previous attempts at managing large-scale projects. The first national program, the Information Management and Technology Strategy, while leading to some innovations in the National Health Service, shared many of its successors' failures, particularly in stakeholder communications. Finally, resources were constrained by the UK Treasury without regard to changes in quality, forcing changes to project scope. The Risk Complexity Index is a tool used to identify when a project is high risk. The Risk Complexity Index measures risk based on technical complexity and project scale. Technical complexity is measured on three factors: technology, the amount of innovation the project produces; architecture, the high-level components and external interfaces; and system, internal software and hardware to be used. In the case of the national program, innovation was required in all three factors, with significant innovation in the interfaces required. For the scale factor, the project team size was well over the 100 required for a maximum factor of 6.6. Here we see the RCI score for the national program was 66, which projects as high risk. The National Program for IT faced several of the risks routinely faced by large-scale projects. A large set of deliverables, including electronic systems for health records, prescriptions and appointments, and a new IT infrastructure for the National Health Service. A diverse group of stakeholders, including health professionals, patients, and the public, and ownership issues resulting from the frequent churn of the project management. This led to continuity issues and a lack of clear leadership. Finally, the project faced widespread changes in technology over the long course of the project. The program's emphasis on a quick start led to the failure of the project to define project requirements and deliverables. This inadequate preliminary work led to a lack of engagement with key health professionals, patients, and privacy proponents. Without early engagement, there were important gaps in both functionality and privacy protection. In addition to the quick start problems, the program frequently failed to adequately test software releases, allowing defects into the production systems to reach end users, fostering lower levels of confidence among those users. There were several strategies to manage scope risk that the program failed to utilize. The principal program shortcoming was the program's failure to recognize the high risk of delays and failure that being such a large project brings and prepare accordingly. Secondly, the earlier Information Management and Technology project established the need for good stakeholder communication. Unfortunately, the program failed to act upon this lesson learned from the earlier effort. Finally, use of project management techniques rather than political dictates would have led to a more realistic timetable and allowed the project to succeed.
According to Kendrick, schedule risks are second most numerous in the peril database after scope risk, representing almost a third of the records, with estimate risk being the most detrimental to the project. And that's what happened with NPfIT. In 1997, the Labour government won the election with Tony Blair becoming Prime Minister. One of his chief initiatives was to reform public services and improve information systems within the national health system, with a vision of leveraging current and previous best practices. Ideally, this would be accomplished by leveraging past lessons learned and incorporating key strategies from previous attempts to update the IT systems. However, while this was a promising and noble cause to pursue, perception has been that the motives behind the effort were less than honorable and focused more towards improving public opinion and possibly influencing upcoming elections. On Monday, February 18, 2002, a seminar addressing the National Program for IT in the NHS was held. Many believe this was a result of a meeting between Prime Minister Blair and the then CEO of Microsoft, Bill Gates, as well as input from other IT providers encouraging the project on a large scale. There was an interesting assortment of attendees, including Prime Minister Tony Blair, of course, Parliamentary Undersecretary of State for Health, Lord Hunt, Department of Health Chief Executive of the National Health System, Nigel Crisp, Director of the Department of Health, Sir John Pattison, representatives from the IT provider Cisco, and the UK Managing Director of Microsoft. Additional attendees included Peter Gershon, who is the Chair, Office of Government Commerce, Alan Milburn, Secretary of State for Health, and Andrew Pender from E Envoy. The meeting was scheduled to last 90 minutes, which the Prime Minister is said to have only been present for half of that time. Considering the length of the meeting, his attendance, and the attendees at that, and that the initiative was so enthusiastically announced so soon afterwards, it is believed that Blair conducted the meeting with the result in mind. This hasty announcement with no regard for past experiences or input from key stakeholders contributed to the project being met with concern and skepticism. No meeting minutes were kept from the meeting, indicating that the meeting began with the plan in mind. Prime Minister Blair strongly supported the need for additional information technology advancements for the NHS. However, he wanted it done as quickly as possible. Health Minister Lord Hunt stated, "The key to stronger central direction is to accelerate the pace of change and make more use of partnerships with the private sector," suggesting that centralizing the IT project would make things easier to implement, thus quicker, and that working with the private sector would also increase efficiency. While driving for a quick completion, Blair asked for a time frame to complete the major initiatives involved in the first phase. The director of the Department of Health, Sir John Pattison, has stated he struggled to get the answer right, knowing that a short time frame was expected, and so responded it would take 3 years. Blair then countered 2 years. Ultimately, 2 years and 9 months from April 2003 was the time agreed upon. The Department of Health stated in its publication Key Elements of the Procurement Approach to the National Programme in January, rapidity. This means the commitment of all parties to do things quickly, listing speed as its first key requirement and mentioning it throughout. The plan was set forth in phases, with each phase having a focus on areas such as infrastructure, application services, and implementation, with each phase becoming more involved. Ultimately, this phase system was designed to provide improvements to IT as early as possible with improved, sustainable, cumulative growth. Phase 0 was set to be from April 2002 to March 2003. During this phase, they would be outlining specifications to be used in information systems, focusing on infrastructure, identifying principles for data, application services, standard electronic patient records, EPRs, and implementation, assessing capacity and competence. Phase 1, from April 2003 to December 2005, would involve infrastructure of expanding broadband access to entire staff and clinicians of NHS and domain-to-domain encryption implemented. Application services, implementation of National Booking Service with 50% of National Prescription Service implemented, 24-hour online access to the National Health Record, implementation of the EPRs, and implementation would be funding plans established and accepted. Phase 2, which would last from January 2006 to December of 2007. Infrastructure would be focused on increased broadband access speed implemented, application services, National Patient Appointment Booking Service and patient administration systems implemented, EPR fully implemented in all hospitals, some clinical terms used across hospitals that were common and consistent. Phase 3, January 2008 to December 2010. Ambulance telemonitoring implemented across all emergency response vehicles, unified health records. However, the plan was not without its challenges. For Phase 0, which was to be from April 2002 to March 2003, less than 1 year after launching NPfIT, Lord Hunt resigned from his role in opposition to the government's decision to invade Iraq. Sir John Pattison also left in December 2003. This was followed by an abundance of turnover, which impacted leadership, but also the business knowledge and history that each of those people had. In April 2005, Connecting for Health was established as a new agency absorbing the NHS and leading the NPfIT program. Phase 1, delays in implementation of electronic patient records due to financial difficulties with a corporation launching it, iSoft. The delays made by iSoft impacted another supplier, Accenture. In Phase 2, by October 2006, Accenture announced they would be leaving the project, in spite of the financial penalty of paying 50% of the total contract value for departing. Choose and Book systems successfully implemented in 7,600 locations by mid-2006. However, it was only used for about 20% of first outpatient appointments. This was primarily due to outdated patient administrative systems. Patient administration systems had only been delivered to approximately 18 of the scheduled 151 NHS locations. And then Phase 3, delays to the National Care Records Service extended to deployment to 2006 initially, before further delays and ultimately the dismantling of NPfIT.
Resource risks, people, outsourcing, and money. There were many failures due to risks taken in the NHS National Programme for IT. The next few slides will outline the resource risks that affected the success of the project. Resource risk deals with the people, outsourcing, and money aspects of a project. While resource risk represents less than a third of the risks in the peril database, when they do occur, they can have a major impact on the schedule and therefore the success of a project. The resource risks taken, especially in regard to the procurement process, may have doomed the project before it truly began. The particularly aggressive procurement process had very little buy-in from stakeholders, which were numerous, and due to a serious lack of project management, underestimated the original budget of £2.3 billion. The NPfIT project was subject to risk involving people, in particular the project stakeholders. Stakeholders are the people who will be affected by the project, in this case the patients, doctors, nurses, and medical administrators, all who would be tasked with using the IT systems that resulted, as well as the government officials who, along with industry-leading suppliers, envisioned the project. It is normal to engage stakeholders during the process where project objectives are defined, in order to ensure the people who will benefit from the project truly get what they need. Many projects have a stakeholder engagement plan to manage effective input from the people the project will serve. The NPfIT project leadership purposely left out or made it difficult for the stakeholders who would actually use the systems and software to supply input. Project leadership saw stakeholder engagement as a roadblock to progressing the project quickly and meeting their fiercely aggressive timeline for delivery. Unfortunately, this left the project at risk in a few respects. First, the project lacked buy-in from the doctors, nurses, and medical administrators, as this group felt they were given little consideration in the design phase. Second, it left the project at risk of missing crucial information required to produce effective software. Lastly, the vendors engaged to produce the software were charged with selling it to an unenthusiastic group of stakeholders. In order to have produced a better chance of success, the project leadership should have slowed the project and included an opportunity to collect information from a carefully selected pool of key stakeholders and users in order to better define the objectives of the project and gain buy-in from the group for a better accepted project across the board. Typically, IT projects are outsourced to companies that specialize in providing the type of hardware or software required to meet the specifications of a project. The NPfIT was no different. The infrastructure and software required to meet the project goal of integrating health system providers and hospitals with electronic patient records across a nation was an enormous undertaking that would require multiple vendors who would need to work together to ensure systems work together seamlessly. The leadership of the NPfIT proceeded along with the procurement process at a record speed, completing it within a year, unheard of in IT projects of this scale. While this would seem a success, there were key elements overlooked in the interest of time. There was lack of definition in the contracting process, which was bad for both sides. For the vendors, this meant they could market themselves based on their past track records, highlighting successes and showing themselves in the best light possible. It also meant they didn't have an entirely clear picture of the specifications they would need to meet and the costs involved in doing so in order to stay on the project. For the project leadership, it meant they felt they had the upper hand in the process. They had vendors competing for their business and declined to form the solid relationships that could have best produced solutions and dialogue necessary to formulate the appropriate expectations and specifications for solutions. During the project, vendors ended up buying out their contracts when they could not perform. The vendors and the project took losses in money and time. Clear specification and development of relationships in the beginning would have helped the process of getting to a successful end for both parties. The procurement process calls for contracting with vendors in a way which benefits the project and protects both parties. The specifications for the project are outlined in a contract, which clearly states the expectations of the client's requirements for the results or products to be produced, the work the vendor is to perform, and the payment they will receive based on the requirements being met. The NPfIT, in their aggressive approach to procurement, chose to contract with vendors in a way that left all parties subject to risk. The contracts were written so the vendors would not receive a large sum of money up front, transferring much of the risk to the vendor. However, as previously stated, the scope and deliverables were poorly defined. This left vendors unable to determine a realistic budget and unable to ensure they would actually be able to perform to the specifications that would eventually become clear. Low bids were produced in order to become a vendor of what could be a very profitable project. Once specifications were more clear as to the project requirements, there were vendors who realized they did not have the capability of meeting the requirements, and those that had not budgeted properly to meet the requirements if they were capable. In the end, vendors bailed out of the project. They ended up paying back fees and took losses, and the project ended up starting with new vendors who would take up additional time in getting up to speed. The lack of specification in the contracts and lack of requests to produce realistic cost estimates hurt the project. The time should have been taken to make these clear definitions, develop relationships, and plan the projects to the benefit of all stakeholders.
As we begin to wrap up this presentation, I'd like to conclude with what we learned. What are the takeaways that we can get as project managers managing our own projects in the future from the National Health System's failures and the risks that they encountered? Well, what were the risks? What factors increased these risks? One is the sheer size of the project. This project was a large undertaking. As project size increases, so do risks. The more stakeholders on a project, the harder it becomes to manage and effectively communicate to keep all stakeholders involved. It is especially difficult to manage a diverse group of stakeholders with varying priorities, expectations, and needs. History matters, whether it was the selection of vendors or the fact that the national health systems had a poor history of managing large-scale projects. History and demonstrable success is a great indicator of positive results. Proper procurement and vendor vetting practices are essential for minimizing risk. Scope creep. The implemental phase strategy created project delays and requirements that were not met and failed to integrate with the overall project. This project was also innovative, and it required a substantial change to the current system. As with the increase in size to a project, so with the level of change required will increase risk. What could the project managers have done differently? Hindsight is always 20/20. This large-scale project could have been broken down into a series of smaller, more manageable projects. You can keep an ultimate goal and/or objective in mind, but by looking at the big picture in small, easily achievable objectives, risk by sheer size is reduced. When creating deadlines and project schedules, those who are performing the task and work should be driving the estimate. This ensures accuracy to project time and schedule estimates And this strategy also speaks to vendor and contractor management, which we will discuss in the next slide. Had proper vendor and procurement management taken place with experienced, trusted companies, there is a higher chance of an accurate schedule estimate. With smaller projects, this reduces the number of stakeholders. But in addition to reducing size, there are several techniques to assess stakeholder needs, via polling, surveys, market research, or simply more upfront stakeholder assessment and communication. A significant criticism in the National Audit Office report was that procurement occurred before clinical engagement. The clinicians were key stakeholders, and perhaps because extensive consultation was thought to slow the process, it never occurred. And this resulted in significant, what some have called disquiet among the clinicians, and the priorities of the program did not fully match those of the clinical community. It is essential to understand those that you serve and to have proper stakeholder management practices. As was mentioned in a previous slide, it is normal IT business practice to utilize contractors for certain aspects of projects. Resources were stretched with this project because too much was done in-house. An agency with a poor track record for success could have recognized their limitations and sought outside resources and expertise to ensure that the project's completion was successful. But proper management, including vetting, needs to occur, which also includes contract management and proper legal practices. These demonstrable successful records will help minimize risk when it comes to completing the job. I'd like to end our presentation with this key takeaway, that evaluation is necessary throughout the project. It is not an afterthought. It is the responsibility of project managers and leadership to consult early and throughout the project's life cycle. Evaluation is an ongoing action that requires communication, thoroughness, and thoughtful planning. Thank you for your time. We hope you enjoyed this presentation.